All right, welcome to documentation dismemberment, everyone. We will go ahead and jump in. This is going to be an outpatient clinic review, so we have no disclosures as usual. Will be kept anonymous as usual. Objectives are the same: to review the updated E&M coding guidelines and how that impacts our documentation. The standard reminder here: the history review system and physical exam documentation no longer have any specific requirements, but you still have to put in there what's medically necessary to take care of the patient and cover yourself for malpractice stuff. It's a short version of that. All right, so jumping into the first part is the HPI. And
not mine. I capitalize everything.
and so just take a minute to review over that. It won't take a minute. I don't think.
No better. It's no better.
I think I know who this is.
Are we supposed to sit
Any questions, comments about
right
the
upper quadrant?
Since Tony's not.
It's localized, but where is it
Where is
localized
it
to?
localized? Yeah. I mean, it says follow up on right upper quadrant. It's not back pain, but
right? So I think it's one of those scenarios where when you're seeing somebody in the continuity of record, just looking at one by itself. But this is what the code, but I think it's interesting to look at because this is what the coder sees.
Sure.
All they can judge you on is what you did in this note. Fortunately for this provider, the rules about not having to meet all the requirements of HPI, this flies because it really does reference what was already kind of covered in the past. So really just a quick update. It's almost, to me, it was more like a progress note in the hospital on the way they wrote their HPI. But that's okay now in the new rules. You can get away with this if you're the one seeing the patient and it's continuity of care. Now, if somebody else has to take this over and you don't know what's going on, now you're having to dig back multiple notes to figure it out. So I think that's where, depending on your situation, what you can get away with and what you should do. At the end of the day, do they tell whether the back pain, I mean, they're addressing whether it's improved or not. I think it's a pretty good statement. It's not controlled, which it plays well into assessing that diagnosis. Anything else on that one?
He said he used it.
but it already has it up there too. So do you need to put if it says it in that additional information? Because I know the nurses put that in. And I was wondering that when I had a patient.
I mean, to me, it seems a little redundant. I probably wouldn't have, but do you, you don't know that you can't see that when you're putting your HPI in either. So probably to cover yourself, because it could just, the additional information, I guess, leaves it vague that the nurse did that. But that's not necessarily something, that's not in the field you can document as a provider until you create your note. So you wouldn't even know it's there. Which is some of the trick with Cerner. You can't always actively see what all is being put into that note, other than your parts. That's something they're supposed to be improving when we go to the cloud sometime next year. You'll actually be able to see more real time what somebody else is putting in that will show up in your note.
But that's not gonna be till next year.
Yeah, it'll be spring.
Your loans will be paid off by the time
Yeah. Nothing you're gonna have to worry about. All right, so just the history section here. Patient does seem to have a few chronic. Any questions about any of this or? More of just see what's in there before we get into the assessment plan. Moving on, next, review of systems physical exam.
Did you mention anything about the abdominal examination? Like finding if there is yes or negative. Like there is tenderness or not.
Was to the point.
It's a there's a lot of words there, but the most point, the key thing that all this is about is an abdominal exam.
It's just
Everything about the HPI, it may be musculoskeletal since it was right over requires back pain. So with no longer requiring these big physical exam templates, I really think it's one of those where more time spent on abdomen and musculoskeletal and leave out all the rest. More efficient, less room for error.
Were the eyes really checked? Was it just?
Oh, yeah. I mean,
I mean,
it is well crafted as an auto text because it is such simple stuff that you
don't even have to touch the patient.
you don't have, I mean, the provider has done a great job tailoring it to something you could just look at, except normal peripheral pulse. Like, how many times you really, I mean, I guess maybe they did in this scenario, but out of all the heart exams that I would put as my standard, normal peripheral pulse is not something I'm gonna do every single time. Be a musculoskeletal, normal range of motion.
Or what?
Of everything? I mean, what? Yeah. Pretty vague. Non-distended abdomen, but they got pain that doesn't.
The most important thing is not addressed here. Like there's
Right.
tenderness or nothing.
I think you could get by with this, but I could see some coder bucking on whether this is really an appropriate physical exam that was was this actually what's documented, what was actually medically necessary to take care of the patient? Questionable. You get a hardliner coder, I could see them kicking that and saying you need more on it or refusing to code it out. It's there, but from a medical legal standpoint, there's, or worse, prior authorization standpoint, like you couldn't defend this. And I don't know how much you all have ever had to defend somebody else's documentation with a peer-to-peer or prior authorization stuff. Like this would be the worst thing in the world to have to defend is somebody else's documentation on that. Because you really can't say much about it other than what's there. Anything else on this one?
I have a question about the last one. It said like ongoing problems and it said elevated blood pressure, no hypertension. Here it's normal. Do you go back and clean that list up then? Take that off? How long if it was just like one elevated blood pressure?
Yeah, so that's probably something that shouldn't have been made chronic. Really not a chronic problem, but left it on there and didn't get readdressed.
Okay.
I think sometimes in the clinic, was the way we operate, is this a primary care visit or was this more of an acute visit? And if they weren't dealing with that, somebody may have left it on there who's following them continuity wise for that blood pressure issue, but then they kind of popped in here for another more acute, for an acute visit. I don't know the answer to that, but I can see that being why somebody did that way, but I don't know. Obviously the answer, that's the strange thing about reviewing documentation is if you're from a coding standpoint, You're only looking at what's in that note, nothing else outside of it. Really, you get to pull into what you do with it. But from a just EHR stewardship, yeah, it should have been dealt with or not left as a chronic and just put in as an acute, this visit only problem. That way it doesn't float around in the chart for 2 years. But I do say that we do a decent job here in this clinic, keeping those cleaned up. You admit enough hospitalist patients and see what other providers and organizations leave as a big mess, and that we do a pretty good job. All right, so getting into the crux of medical decision making with the assessment and blame. Yeah, what right of requirement pay. Very, I mean,
Very straight on bars, but
right of required paying in this case was very.
was very, very.
This is,
Very overarching.
this is a yearly exam.
Stresses me out, that's all.
Yeah, so what are the issues you run into? You only got one diagnosis. I need to prove. Is there only one diagnosis being correct?
No.
You sure there wasn't anything else on there?
No, I'm sure, actually, yes, I am sure there was nothing else on there. This is it. It's cake. So I mean, there's a lot there.
Yeah.
But there's one diagnosis. I mean, that becomes the crux of how we then judge this thing from medical decision making and coding standpoint. So how many diagnoses do you think are actually addressed in this plan?
At least 3.
So issues could be on there.
Yeah. Back pain,
Vaccination.
vaccination, right for quadrant pain, those 3.
Fatty liver.
Urine symptoms, I don't know.
Why did they
When
put
it's-
a back strain as a diagnosis for the ball chain?
It just
In the
says
very
patient
beginning.
declined again. Is that for the UA?
PT.
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 Oh, yeah, yeah, capital.
Yeah, right, you're right.
Is using physical therapy, so. That. Right, I mean, I would say
That was a
right,
good use of using.
yes. Strategic capitalization.
Cause nothing else.
I'm all for it. Not my note, but I'm a very strategic capitalizer. Cause I don't like capital. Yeah, I mean, you got right over quadrant pain, you got back strain, some sort of musculoskeletal problem, which is really different. It's still almost in a differential diagnosis state to me as to what this pain is. And of course, you can actually document that and get credit as a problem addressed. If you explicitly said differential, like this is what they train you to do in the ED and urgent care, differential diagnosis considered. You can get away with that and still get credit for those different problems towards this. But I think you have to explicitly say it more than what this is. Because this almost to me says we're ruling out, well, we considered the diagnosis to rule it out. But you don't get credit because it's not really, there's no diagnosis attached to it. Not sure about fatty liver pain as a real thing. You come across fatty liver pain,
They've had a lot of hepatomegaly, but.
I mean, you'd have
But
to
if it's
have,
just having fatty liver now, not to have.
I guess it's theoretically possible, but I've never heard such thing. They'd have to be getting awfully, it'd have to be getting awfully,
Fat
it
collapse.
it would have to be the fat would have to be expanding pretty quick to stretch the capsule enough acutely to cause pain.
Yeah.
Cause chronically over time, what it doesn't cause, usually if it happens,
Did they mention what the duration time for the starting the symptoms? Because this is the second visit,
right, so it's not really clear.
so I cannot tell is acute, subacute, is a chronic problem.
Where are the labs?
Well, so I mean, you have to default assume kind of it's an acute, like this is really,
That's what I'm saying, where are the labs?
True, did we get it?
they're not in the note. Like this is all you got.
Someone,
So you got patient instructions and figure orders from referrals.
For your back pain or pain.
It's exclamation point. It's
Yell
an
at
exclamation point. It's not paint, it's pain with an exclamation.
There's two explanations.
that's means like, I'm not sure, is this the back pain one?
Right, but follow up for your back pain, but that wasn't a diagnosis.
So why develop flash from the volatile girl?
Huh?
But if you develop rash, please call.
You call someone. Just call it. You call a family member.
But you gotta do it with excitement.
Okay, they're not gonna defend themselves, okay?
We get them for your back, but your front of your stomach hurts.
Right up the market.
Yeah, so now there's no lab, so the UA, that's all that's in the note, is that statement there, the actual.
And they didn't even say if
Dipstick
there was like
results.
previous labs that they reviewed or anything, so
Yeah. Well,
it's just
the
like we kind
imaging,
of ignored it.
past imaging review,
Well,
very straight.
Sure, very
But
straight
which one,
lumbar
but which,
spine.
which images? Is the last visit images, is like 2 years ago images?
Right. See, I think it's important to kind of put something on there, especially if you're going. I don't think you could ever get credit for that statement. Past imaging reviewed with very straight lumbar spine.
Could be when he was 4 years old.
That's this is one of these where you did the work, somebody did the work, but they're probably not gonna get credit for it. I mean, maybe you got a loose coder who let that slide, but it doesn't have the magic words in my interpretation. Studies independently reviewed by me. That's where a good auto text.
Very straight lumbar
Images
spine.
from
Yeah, I
July.
mean, like very straight lumbar spine is enough probably, but just past imaging reviewed, that doesn't say whether you review the images yourself, whether you reviewed a report. I doubt radiologist put in the report, very straight lumbar spine, but
Just straight, very straight.
Very-
very straight.
But whereas like date is important.
Yeah, I always kind of reference at least
Reference the date.
what month and year.
I feel like the timeline for all of it is not really, we don't have a very clear timeline of how any of this is played out.
Right, which makes it hard if you're the coder trying to figure, I mean, because we're playing the coders. If we got all these questions about what's going on, then you're gonna have to then assume it's the lesser of problems.
Maybe
Because
the
it doesn't feel like it's a chronic problem. Let's get in the MDM. So just to kind of review between the 21 guidelines for outpatient, it's all based on medical decision making alone. That's in our diagnosis data risk buckets. And then your final MDM is based on the highest 2 out of 3 levels for those diagnoses data and risk. Example. So then I think this is really this gets an important case when you start getting in not only just our standard, we're looking at a 4. You're trying to find 2 stable chronics or 1 uncontrolled chronic. There's nothing in here is really chronic. So this is where we're gonna have to dig a little deeper to figure out how do we salvage this thing. So now you got into. We haven't got, I don't think in these sessions we've really gotten into this. It seems like an acute problem. But is it uncomplicated? But then you get into, is it self-limited or minor as a straightforward? Is it acute uncomplicated? Is it a stable acute? Or is it a acute illness with systemic symptoms or acute complicated injury? So acute has so many different definitions and they're all very gray as to what falls into each category.
Yeah.
So then you have to kind of get into these diagnoses definitions to decide what you think they are.
Yeah, I'll go.
It seems like acute,
stable.
it seems like acute
The key
state,
stable on this for me.
but you could also see where if you went down the back pain and was a self-limited problem that didn't resolve as expected. But I really think you would have to trump up how you call an acute uncomplicated illness or injury. Like, how would you ever get that out of the document? Some of their definitions don't exactly fit well to, unless you explicitly remembered to call it these things. I don't know how a coder would ever figure out the difference. Because when you flip back to, luckily, acute stable and acute uncomplicated are in the same category.
But I mean, the diagnosis is big here because like you mentioned, right upper quadrant pain, but all the concern was like back pain.
Right.
So is there any ultrasound for the liver? Is there any CMP or transaminitis? What's going on?
No. I don't think so, but I don't recall. And from a coding standpoint,
I mean,
You don't get to
if you
that.
have it, just put it in, so we'll cover that.
right,
That was my,
yes,
Yeah, because if the fatty liver was recently diagnosed based on ultrasound for right upper quadrant pain,
there is a CMP at some point, but I don't remember how long.
could have been
It
a long
could have
time
been 3
ago.
or
or
6
could have
months
been
ago.
in-
I think it was a while ago,
Yeah.
and then this new pain thing comes up and it's this, yeah, there's a lot
could be a stone there on it.
of
In the
timeline,
gallbladder,
Yeah.
cholecystitis.
a lot of timeline missing. But I think it would be very hard to get into the moderate category with anything we've got documented. Okay, so as we play that out, we got the one. And so, I mean, really, it's all over the place and you don't know the timeline. It doesn't seem like an undiagnosed new problem, but then right upper quadrant pain. And then it was treated as back pain and now it's called right upper quadrant pain. So it gets a little confusing. Is that really new or is it old? I agree. Acute stable is what I would label it as. So what if you pulled in some of these other diagnoses? If the fatty liver's been addressed, you could make the argument that but it's just sort of in this offhand fatty liver pain. Could be fatty
Did you
liver
make that a
pain.
diagnosis?
Well, does the patient already have the diagnosis? That's
That
the,
was in the chronic, like,
Oh,
because then you could have a chronic, potentially unstable problem that now suddenly changes your entire dynamic of what this looks like.
and already on a statin. What is that?
Yeah, I mean, so you've even addressed like what they're doing for the fatty liver. So at worst, you've got a chronic stable and you've addressed it, but it's not really put in there as a true diagnosis. I don't know I don't know how you count that. But it seems like the complexity here is a little higher end than getting credit for one acute stable problem. Because we considered all this differential diagnosis of these other problems, whether it's musculoskeletal, whether it's fatty liver, whether it's a nephrolithiasis. The way it's the way it's documented, there's no credit for any of that thought process going into it.
For me, I'll add musculoskeletal pain, one of them, with like.
I think you can get away
Because I'm
with that.
covering the ball tearing as well, so that's maybe.
Yeah, you can,
explain.
certainly the traditional way would be to put them in as all individual problems, but using a differential diagnosis considered and just having the.
Like doing abdominal pain within a bunch of different.
Formatting some of these differentials that are being discussed into something that's clearly, these are differential diagnoses being considered. Another simple auto text. Stuck in there in front of some of this stream of consciousness documentation would have actually gotten credit for stuff that's not, that I don't know how you give credit for right now. Because there's really a lot of medical decision making put in here. It's just not structured in a way I think a coder could do much with it. So what would a acute stable get you to?
3.
So it's a 3, but with all the stuff we just talked about, I think you lump in those differential diagnoses and what you're considering and some more problems. I think you could argue, and then fatty liver being chronic, you start pushing that towards a 4. All right, so from a data standpoint, of course, we're always trying to get the level 4 in data. That's, if you can kind of remember those the category 1, 2, and 3, category 1 being any 3 of those test documents or using independent historian, which an interpreter does not count.
I mean, I'm not
It's
able
part
to
of
get,
doing business.
I'm not able to get 3 in this case.
Category 2 is independent interpretation, and category 3 is discussing it with an external provider. All right, so what can you give credit? So category 1, how many category 1s?
I can say category 2.
I mean, so category 1,
Need to interpret a lot of things. Actually, he's spent good time to say something here, but it's not account against the diagnosis or like with the diagnosis. So you cannot use that as a source. Like your analysis, one of the things he mentioned, but
what was that? So that'll get you category 1 credit.
Yeah.
At least mention was your analysis.
that's maybe the only thing I can say. X-ray doesn't say anything.
Well, but it's still, if anything, it's what it is. Like, so it definitely counts as category 1.
So put it in, no.
Because he's clearly documented a result of something of this imaging report, that it was reviewed.
The majority of the residency program
That's
is.
everybody except for
30.
3. The 2 of those are in there, so what's the chances of it in there documented?
It's not bad.
I know.
So it wasn't.
Yeah, I would lean towards there's 2, but you need 3 to get a 4, and there's no way to squeeze the 3rd one out of that. All right, so from a category 2 standpoint, which is,
I'll go with 2.
and so what is category 2?
To get like, like straightforward, like,
No, category 2.
No.
data. I think one or two of the
It's in interpretation.
interpretation, yeah. One interpretation or
One
two
interpretation.
or two like
No,
document.
you need 3.
Oh, 3, yeah.
Category 1, you need 3 to hit level 4.
Hmm.
You need 3 items. So that's where he could only get to a 2 from this for category 1. So that's stuck at level 3. From category 2, it's probably a 0 because like we discussed, I don't think passing an interview with a very straight lumbar spine is really going to meet the threshold to give credit for category 2. But the great thing about it is category 2, like that right there, would have been a level 4 if documented appropriately. If they actually looked at the imaging and documented that correctly, that's automatically a level 4 without the UA or anything in it. Because independent interpretation of the test is a higher level of medical decision making, and the threshold there is lower to get that level 4. And then, of course, nobody's discussed with on this, so level category 3 is that discussion on an external provider. So none of that happened, so. Data level here is
Oh,
2. Well, so it should be, maybe that's supposed to be a level 3.
I don't see 2 here. I don't see 3 here.
Well, you gotta have 2 to get level 3 in category 1, right? So level 3 is 2 from the following.
I mean,
So
there is
either-
no,
So if there's a review of the UA and review of that X-ray. That's 2 from category 1. And then it gets you a level 3.
but he didn't, like, if you look at this, he didn't make the 3 of them from the category 1.
Right, that's why he's not a level 4.
Yeah.
That's what I'm saying, it's a level 3,
Cause you just need any of,
because you only needed 2 from category 1.
oh, cause he ordered the UA.
Or
He just
it's
did
both.
UA.
And reviewed it, so that's okay.
You can't get credit for both, you only get credit once.
So the only thing is order, like, he didn't order, but he read it, so that's 1. External note, there's no external note.
Right. But the
And he
UA
reviewed the result, yes.
reviewed the result, yeah,
I
at
get
the
2.
very least, reviewed the result of the X-ray.
So that's good
Okay.
too.
That's where to
Okay.
me, because it's not documented correctly. I know the X-ray was reviewed because I reviewed it with the provider.
You almost said it.
So we could have. I know that the level, that the category 2 was met, but the way it's documented would not meet that, and the coder doesn't actually know what you did. They only know what you documented. So that's why it's only a level 3, because of the UA and the X-ray are 2 of the category 1. Social determinants of health is your other easiest way to get that level 4, if you can somehow tie that in.
What's that again? I'm sorry.
Social determinants of health is it's an easy bar, especially with our patient population. It's an easy way, because they have transportation, insurance coverage, financial issues, housing insecurity, food insecurity, any number of things that are over there on the right side of their social determinants of health. My guess is, being an immigrant, having used a Mandarin interpreter, there's probably some social determinants of health at play for somebody that speaks Mandarin only, living in Glasgow, Kentucky. Not exactly easy life.
A little bit of social isolation.
There's not exactly an easy road to hoe in that. So there's probably something in there that could have been played into 4 there. But prescription drug management, I think, becomes an interesting question in this, because OTC meds is a 3, prescription drugs are a 4.
Yeah, I needed.
So now how do you feel about
I mean, Voltaren is
prescribing
like
over the
autism.
counter medicine? Is it a 4 or is it a 3?
But he mentioned he offered the physical therapy.
Physical therapy
And get
counts
legal.
for nothing
Oh.
in the current system, which I do think it's ridiculous. But
Yeah, because like you do something like it's a referral.
we'll file a complaint with Medicare and see if they address it.
Good luck.
Good luck.
But I really don't know what to call this. To me, it's an OTC med, just
Yeah.
because you put a prescription for it. Prescribing something the patient can get over the counter shouldn't trump that. You might. The problem is, you're gonna probably fool your coder, because there is a prescription on there.
Mhm.
And they're not gonna realize over the counter med. Give you level 4 credit when maybe you didn't deserve it, and then just hope you don't get audited.
But let's say he put like physical therapy, discuss like exercises, put some hot compression, whatever, things like that. Does that change anything?
It's not,
Not in this.
is not here. PTOT is level 3, actually, there you go. So you don't get
Not getting credit on that, yeah.
Yeah, so you get level 3 credit, but we're trying to get to a 4.
Yeah.
Level 3 is so easy to get, you really won't ever have to try to get that.
There's like 3.
See, I think we're stuck with a 3 here, but how could it have gotten to a 4?
If they just put some simple like things like with a date for the X-ray,
Continues that.
continuous.
Right, so that's the thing,
Continuous
it's
staffing.
already, the thing is already mentioned, it's just not structured in a way of a diagnosis that gets credit
Continuous
for it.
staffing.
Had fatty liver been its own diagnosis and said continue statin.
You had-
It's a level 4. But I really don't think. I mean, so, there you go. I'm just Voltaren topical already on statin and shingle vaccine. I don't see where that gets you a level 4. Close. A lot of
Very,
good
very,
evidence.
very.
Very good.
Could replace 2 words with 1 and it would have been.
Yes, and that's why I thought this was a good one to review, because that's the
Very good.
nuance. The nuance of what it looks like from a coding standpoint. All this work was done and this provider lost 0.4 RVUs. for it.
2, 3, 3, so 4. 3.
So. In the end, I think it's a 99213. But could have easily been a 99214, even for what seems to be a very simple problem that was addressed. There was a lot of work done. Didn't get credit for.
With your attestation will be.
My attestation will be for, well, I mean, we don't play
Because
around.
you said earlier, mentioned the.
I didn't see the patient, so you can't
uh,
fight. Well, my attestation, because I think I mentioned that we
The
reviewed.
X-ray review there.
I'll probably put that in my attestation, but I didn't see the patient, so it still didn't count because of GME rules, but
That would be an independent historian,
what?
someone else attesting it.
No, that's just me. Or if I documented that I reviewed and interpreted the X-ray myself,
All right.
like that would have covered up the lack of documentation by the resident. But because of Medicare rules, I didn't see the patient. I just precepted it, so we can't bill more than 3. There's the usual references. Any questions? That wraps it up then.
Thank you so much.